Hi, my name is Nancy Cho. I'm an assistant professor of surgery at Harvard Medical School and an associate surgeon at Brigham and Women's Hospital. Today I'll be speaking about the current management of thyroid, parathyroid, and adrenal lesions. I have no disclosures. Endocrine surgery is a relatively new subspecialty of general surgery with approximately 25 fellowships that participate in an annual match sponsored by the American Association of Endocrine Surgeons, or AAES. Endocrine surgeons primarily specialize in diseases of the thyroid, parathyroid, and adrenal glands, with some surgeons also focusing on neuroendocrine tumors. Endocrine surgery is a rapidly advancing field, and there are very frequent changes in surgical technique, imaging, and guideline recommendations that occur frequently. So today I will touch on several of these recent changes that have altered surgical management of endocrine diseases in the past few years. So most of my patients come to see me for thyroid problems, and as we know, thyroid disease is extremely common. Many people would like to blame their thyroid for everything, such as weight gain or weight loss, fatigue, anxiety, depression, hair loss, GI upset, headaches, reflux, all sorts of things. But for the most part, the surgical management of thyroid disease boils down to a few main issues. Many of my patients come to see me for large thyroid nodules or goiters that develop compressive symptoms. I also see patients with Graves' disease, refractory to medical management, or often I see young women who are pregnant or wish to become pregnant and don't necessarily want to go through the radioactive iodine ablation treatment. Finally, many patients see me for indeterminate nodules or thyroid cancer. And here you can see that the rate of thyroid cancer is actually increasing and is growing 7 times faster than that of breast cancer. And in fact, thyroid cancer incidence is definitely increasing. In 2013, there were roughly 60,000 new cases diagnosed that year, and there was a definite increase in the slope, as you can see here, over the past few decades. So whether this is an environmental effect or the result of incidental findings from increased imaging is somewhat unclear. The good news, though, is even though the incidence of new cases is rising, you can see here that the mortality is relatively flatline, and it's actually still very low. So overall, this suggests that patients with thyroid cancer do very well in terms of survival. Here you can see that thyroid cancer diagnosis has increased at a rate that's faster than that for any other cancer, so 6.5% over a 10-year period. Melanoma and a few other cancers are also increasing, whereas others like breast and colon cancer are fortunately decreasing. And this is likely due to an improvement in detection and removal of precancerous lesions. Thyroid cancer is predominantly a disease that affects women, and men that are diagnosed, as shown here, often tend to have larger tumors and more advanced disease at initial presentation. Papillary thyroid cancer is by far the most common type. It represents about 75 to 85% of cases that are diagnosed. Followed next is follicular thyroid cancer, which accounts for about 15% of cases. Anaplastic disease is the most aggressive form. Fortunately, it's very rare and represents about 1% of the cases. It carries a particularly poor prognosis, and most patients don't survive beyond a 4 to 6 month period after diagnosis. The few that are cured are often because they're discovered incidentally following a total thyroidectomy for a separate indication. And finally, medullary thyroid cancer is also quite rare. It's about 3% of the thyroid cancer cases that are diagnosed. And this type carries a variable prognosis depending on the time of diagnosis. Since surgery still carries the best chance for treatment and cure, there aren't very good medical therapies for medullary or anaplastic thyroid cancer. However, there are several options that are currently in clinical trials, and response rates are variable for these types. Overall, the prognosis for differentiated thyroid cancers such as papillary and follicular is very, very good. Here you can see for stage 1 and stage 2, it's very high. I wouldn't say it's completely 100%, but for most patients with stage 1 or 2 disease who receive appropriate follow-up and appropriate treatment actually do very, very well. Thyroid cancer is a bit unusual in that it takes age into account for staging. So patients with differentiated thyroid cancer under the age of 55 are grouped into either stage 1 or stage 2, depending on the extent of disease. And again, this speaks to the overall favorable outcome for this type of cancer. And of note, the age was just increased from 45 to 55 in the 8th edition of the AJCC guidelines. So let's talk a little bit about thyroid nodules. They're exceedingly common, and I always tell patients that if we took an ultrasound machine around the clinic, many people just working in the office would have incidental thyroid nodules. So for the most part, these are all benign, but there is still a sample of the nodules that do come back with malignant or indeterminate cytology results. So the best imaging modality is by ultrasound, and this is performed by a radiologist typically and under a dedicated neck ultrasound protocol. And this enables the radiologist to characterize the nodule and assess its risk for malignancy. The American Thyroid Association, or ATA, published guidelines in 2015 describing ultrasound features that correlated with an increased risk of malignancy. So at the very top here, these nodules have a very high suspicion for malignancy. And these characteristics include things like calcifications, irregular margins, hypoechoic nodules that are taller than they are wide, extrathyroidal extension, and other features. So these oftentimes will encourage a radiologist or an endocrinologist to recommend fine needle aspiration for these patients. And then, as you can see on this chart, that the characteristics then decrease in terms of risk of malignancy all the way down to these cystic lesions, which are very often benign. In general, nodules that are greater than 1 centimeter, enlarging, or have suspicious ultrasound features should be recommended for fine needle aspiration. And again, this typically occurs under ultrasound guidance. You can imagine that for very small nodules that are about 1 centimeter in size, they can be difficult or impossible to palpate. So having that ultrasound there is really helpful for being able to see that the needle is aspirating the appropriate nodule. Typically, about 3 samples are collected and sent off for pathology review. And a 4th sample is sometimes collected and saved in case of an indeterminate result. So the Bethesda classification or system is widely used to characterize results of the fine needle aspiration, and they are categorized into groups 1 through 6, and all of these correlate with a risk of malignancy. For non-diagnostic results, which are Bethesda Category 1, these carry a low likelihood of malignancy, and very often there's just a repeat ultrasound and FNA that is recommended just to make sure that there's no cancer that is missed. For benign lesions, which are Bethesda Category 2, again, the likelihood is really quite low, and oftentimes these nodules can be safely watched, and this typically includes serial ultrasounds and clinical examination. Repeat FNA can then be performed if the nodule enlarges or takes on suspicious appearing features on ultrasound. And our group was in particular interested in these benign nodules when the nodules themselves are large, so over 3 to 4 centimeters in size. And we actually found in our cohort that the false negative cytology rate was about 10 to 15%. And this is most likely due to a sampling error. So I often tell my patients that as the nodules get larger and larger, it's difficult for this small needle, which only takes about 3 samples, to really accurately assess the nodules. And it's not uncommon for them to miss a smaller cancer that's being harbored in the larger lesion. So for this reason, our general practice is to at least discuss resection of these large nodules despite a benign FNA cytology result, just so that we don't miss a cancer that's smaller or lurking within these lesions. So now moving on to Bethesda category 3 and 4, these are indeterminate lesions with an increased likelihood of malignancy, so anywhere between 5 and 30%. Frequently for these lesions, a repeat FNA is performed, and then the sample can be sent for molecular testing. And this uses a gene expression classifier, which I'll discuss later in the next few slides. For some of these For some of these indeterminate results, many patients actually just prefer to move forward with diagnostic lobectomy or surgery rather than repeat FNA, as it can be frustrating for patients to go through repeat samples and repeat fine needle aspirations. And certainly surgery is a more definitive approach. For nodules that are Bethesda category 5, you're now looking at a likelihood of malignancy that is over 50%. A few years ago, I would generally recommend total thyroidectomy for these patients. However, recent ATA guideline changes, as well as the introduction of NIFT-P, or non-invasive follicular thyroid neoplasm with papillary-like nuclear features, have changed management such that most endocrine surgeons are now offering lobectomy for Bethesda category 5 nodules that are under 4 centimeters in size. And exceptions to this recommendation should always be considered, of course, depending on the individual patient preference. Finally, for malignant lesions, or Bethesda category 6, the likelihood of malignancy is definitely quite high. So for these patients, we recommend either total thyroidectomy or thyroid lobectomy, depending on the size of the nodule and patient preference. In 2012, Alexander et al. Published a report in the New England Journal of Medicine examining the utility of a gene expression classifier to risk stratify indeterminate nodules and improve preoperative risk assessment. So the Afirma test analyzed the mRNA expression pattern of 167 genes in 265 indeterminate nodules. Based on this analysis, nodules were classified as either benign or suspicious. For benign results, the likelihood of cancer now drops to less than 5%, and patients could then be counseled against surgery in favor of surveillance. And this is ideal for patients who are averse to surgery or have small, non-symptomatic nodules. For suspicious results, the likelihood of cancer now increases to about 40 to 45%, so diagnostic lobectomy or total thyroidectomy should be discussed as the next step. In 2017, an enhanced version of the Afirma test became available with improved specificity. In addition to Afirma, other mutation panels, including ThyroSeq, are also available. And molecular testing has really changed how we view indeterminate lesions and has helped increase our understanding of the molecular pathways that drive tumorigenesis. However, just because a nodule expresses certain oncogenes does not necessarily dictate its biological behavior. In 2016, Nikki Farath et al. Published a nomenclature revision of encapsulated follicular variant of papillary thyroid cancer. These lesions were previously viewed as indolent tumors, but they were still treated as cancers, and this involved total thyroidectomy and postoperative radioactive iodine ablation. Nikiforov's study followed 109 patients, all with encapsulated follicular variant of PTC, and these patients underwent either lobectomy or total thyroidectomy, but did not receive radioactive iodine ablation. So none of them actually showed evidence for disease after following them for an extended period of time ranging from 10 to 26 years. Based on this biology, the researchers proposed a nomenclature change for encapsulated follicular variant of PTC to NIFT-P, which stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features. The authors concluded that these tumors were not invasive and should be treated with lobectomy alone. So I actually tell my patients that even though these tumors do not appear to have malignant potential, it's still a good idea to remove them because you never know if they'll end up accumulating mutations, which will actually lead them to become more invasive cancers. So unfortunately, it's difficult to diagnose these lesions preoperatively, although studies have looked at features on FNA or ultrasound to help predict NIFT-P in the preoperative setting. At our institution, we were interested in examining the effect of the nomenclature change to NIFT-P on the rates of malignancy, invasive malignancy in our thyroidectomy patients. So in a cohort of 353 patients, 26 were diagnosed with NIFT-P on surgical pathology review, and the majority of these cases demonstrated indeterminate FNA cytology preoperatively. Invasive malignancy rates decreased from 4 to 1% in benign nodules or Bethesda category 2, from 33 to 18% in atypical nodules, and this was a significant finding, from 29 to 22% for nodules that were suspicious for follicular neoplasm, and from 91 to 73% for nodules that were suspicious for malignancy, and this was also a significant finding. For malignant nodules, Bethesda category 6, the rates of invasive malignancy dropped from 99 to 98%. So overall, the decrease in invasive malignancy was 7.3% for this entire population and 13.1% for the nodules with indeterminate FNA Bethesda category 3 through 5. And in terms of surgery, among the 26 NIFT-P patients, 17 underwent thyroid lobectomy, as shown here in yellow, whereas 9 underwent total thyroidectomy. So as we discussed before, the appropriate surgery for NIFT-P is actually lobectomy. So 8 of these 9 patients with total thyroidectomy could have been definitively treated with a lobectomy alone. So talk about overtreatment for these NIFT-P cases. Given these findings, if I now receive a cytology report that is top-line with features suggestive of NIFT-P or falls in the indeterminate category and the nodule is under 4 centimeters in size, I do tend to suggest lobectomy over total thyroidectomy as the field becomes more conservative in its surgical approach. So this is a good segue into discussing the recently revised 2015 ATA guidelines that were published in Thyroid for patients with differentiated thyroid cancer. One of the biggest changes affecting surgical management involves treatment of differentiated thyroid cancers that are between 1 and 4 centimeters. For cancers that are under 1 centimeter in size, that do not have any lymph node metastases and no signs of extrathyroidal extension, lobectomy is the appropriate treatment, and this is consistent with previous guidelines. For patients with cancers that are over 4 centimeters in size, that have gross extrathyroidal extension or have apparent lymph nodes disease or distant mets. Again, the recommendation hasn't changed and consists of near total or total thyroidectomy. However, for patients that fall into the category of size between 1 and 4 centimeters, without any sign of extrathyroidal extension or any lymph node disease, the current recommendation has now changed to simply a thyroid lobectomy. And this should be discussed with patients as a surgical option, whereas previously all these patients would undergo total thyroidectomy and most of them would receive postoperative radioiodine ablation. So this paradigm shift is recommended due to studies that have demonstrated similar outcomes following lobectomy versus total thyroidectomy in this cohort of patients. And again, selective radioactive iodine ablation should be given based on risk of recurrence. When I talk to my patients, I do tell them that lobectomy has the advantage of decreased risk to the contralateral nerves and parathyroids, as well as the decreased need for thyroid hormone supplementation after lobectomy. However, it can be challenging for endocrinologists since thyroglobulin, which is used as a marker of disease recurrence, is not very accurate when patients simply have a lobectomy alone. So for this reason, some endocrinologists do prefer completion thyroidectomy for large thyroid cancers so that they can monitor the thyroglobulin levels better. And also some of them do still recommend radioactive iodine ablation, which typically is only optimal when the entire thyroid is removed. Patient and physician preference are still critical for making the appropriate surgical recommendation. So one can imagine that surgeon adherence to new guideline recommendations does take time and conscious effort. To investigate this, we looked at the data at our institution and measured rates of completion thyroidectomy for 2 years, and this was before as well as after the guideline recommendation changes were published. Microcarcinomas were excluded, and these were all 1 centimeter in size, as the updated guideline recommendations did not change for this group. And we also performed a subset analysis for all those lesions between 1 and 4 centimeters. In our study population, we found a total of 303 patients that underwent thyroid lobectomy for malignancy. Of these patients, 163 met our criteria and were included in the study. 63 patients were in the pre-group and 100 were in the post-group. So in the pre-group, 41 of these patients underwent completion thyroidectomy, which is about a 65% rate. Now, compared to the post-group, which were about 43 of the 100 patients, for a 43% completion thyroidectomy rate. And here you can see that the decrease in this rate was about 34%, which was a significant finding. And again, this was for all thyroid nodules, excluding the microcarcinomas. Now, when we analyzed the study population and just looked at low-risk patients in the 1 to 4 centimeter thyroid nodule size, we found that 35 patients were included in our pre-group and 60 were included in our post-group. So for completion thyroidectomy, 17 were included for a rate of 48.6%. Whereas in our post-group, 15 patients underwent completion thyroidectomy for a rate of about 25%. And here you can see this is a 48.6% decrease in the rate of completion thyroidectomy, and this again was a significant finding. We looked at patient and pathology characteristics associated with completion thyroidectomy. That were associated with these patients, and found that for the most part, greater tumor size, capsular invasion, and subcentimeter multifocality were associated with completion thyroidectomy in the low-risk post-guideline patients. So we concluded from our study that the rate of completion thyroidectomy did decrease significantly by about 49% for these low-risk patients with differentiated thyroid cancer between 1 and 4 centimeters, and this demonstrated gradual adherence to the 2015 ATA guidelines. However, 25% of patients still underwent completion thyroidectomy, suggesting that additional factors are still influencing the decision for further treatment. Recently, there was an editorial in the New England Journal of Medicine discussing that while thyroid cancer rates are still increasing, as we know, the mortality rates are flat. However, more and more patients still seem to be undergoing total thyroidectomies, whereas the data do suggest that patients with small thyroid cancers are being overtreated with total thyroidectomy and radioactive iodine ablation. So while the overall trend, both medically and surgically, in the management of thyroid cancer seems to favor a less is more approach, I do think this bodes well for the majority of our patients. But the trick will be to make sure that these recommendations are being adhered to nationally, as well as to ensure that we remain vigilant in monitoring or appropriately treating these patients with aggressive disease so that they're not actually undertreated. So as we move on to discussing parathyroid disease, don't forget that thyroid cancer rates are growing 5 times faster than that of testicular cancer. We've come a long way in parathyroid surgery since Sir Richard Owen, shown here, first discovered the parathyroid glands in 1850. And this was done during an autopsy of an Indian rhinoceros. He described the parathyroid gland as a small, compact, yellow glandular body that was attached to the thyroid at the point where the veins emerge. And many years later, in 1880, Ivar Sandstrom, at the time a Swedish medical student, first described the parathyroids in humans. McCullum and Voetlin made the physiologic connection between the parathyroid glands and calcium regulation by observing that the removal of parathyroid glands in dogs resulted in hypocalcemia. Felix Mandel, showed here, then went on to perform the first parathyroidectomy in a human patient, and this was in 1925. Unfortunately, the patient's disease recurred, and he later succumbed to what was probably a parathyroid carcinoma. In 1928, Isaac Olch performed the first successful parathyroidectomy at Barnes Hospital in St. Louis, where the term hyperparathyroidism was first coined. Currently, there are approximately 100,000 new cases of primary hyperparathyroidism diagnosed in the United States each year. Of these cases, the majority are represented by a single parathyroid adenoma, followed next by 4 gland hyperplasia, multiple adenomas, and very rarely parathyroid carcinoma. Most patients are diagnosed after discovering hypercalcemia as an incidental finding on routine laboratory tests. And in fact, primary hyperpara accounts for the majority of cases in the outpatient setting. In these patients, they will have elevated calcium levels typically, and the PTH levels that are then sent off are often inappropriately elevated. However, sometimes they're in the normal range, and I always tell patients that high normal parathyroid levels are still indicative of the disease, since they should actually be quite suppressed for an elevated calcium level. And this is a really critical take-home point, because otherwise physicians can be fooled by normal parathyroid hormone levels. Other causes in the differential can include malignancy, drugs such as thiazide diuretics or calcium supplementation, lithium use, secondary hyperparathyroidism, and familial hypocalciuric hypercalcemia or FHH. Of note, long-term lithium use can be associated with the development of multiglandular disease as opposed to a single adenoma. And FHH is really quite rare, but should be considered if there is a family history of hypercalcemia and low 24-hour urinary calcium levels are found, especially in young patients. In this situation, these patients will not benefit from parathyroid surgery. Here you can see a typical range of parathyroid hormone levels as they correlate with calcium in different disease states. The normal curve is shown here in green. So as calcium levels rise, the PTH levels should drop accordingly. For patients with classic primary hyperparathyroidism, shown here in blue, hypercalcemia is associated with elevated PTH levels, but they can also be in the high normal range. So again, that's one of the most important take-home points, that hypercalcemia with a normal PTH level is still likely to be primary hyperpara, given that the PTH levels are inappropriately increased. And finally, for patients with hypercalcemia associated with malignancy, the calcium levels are indeed high, but the PTH levels are appropriately suppressed below 20. To diagnose primary hyperparathyroidism, a detailed history is critical. So there are classic clinical manifestations, but they're not always present. Some of these can include painful bones, kidney stones, abdominal groans, psychic moans, and fatigue overtones. Some patients, again, may not report any specific symptoms, but they may express noticeable improvement following surgery. This demonstration of subjective improvement has been published in the literature and documented using objective criteria such as SF-36 surveys of emotional and physical well-being. As I mentioned before, elevated calcium and inappropriately elevated PTH levels are the hallmark of primary hyperpara. So for straightforward cases, I forego other laboratory tests since the diagnosis is clear. Some cases can be a little bit more subtle and have high normal calcium levels with normal PTH. So in this case, I will sometimes send an ionized calcium as well as a 24-hour urine calcium. If these values are elevated, the patient most likely has primary hyperparathyroidism. If the 24-hour urine calcium is low, then my suspicion for FHH will be higher. Although, again, this diagnosis is quite rare despite being a favorite topic in our textbooks. Normal calcemic primary hyperpara can be a challenging diagnosis, and in this case, ionized calcium can be quite helpful, as well as ruling out secondary causes of hyperparathyroidism. In this case, many patients will suffer from progressive bone loss, so prompt surgical intervention should be considered. I don't really find vitamin D levels that useful since vitamin D deficiency is usually correlated with low calcium rather than high calcium levels. And in this case, the patient usually has a compensatory secondary hyperparathyroidism. However, in some cases, vitamin D deficiency can mask an underlying primary hyperparathyroidism. So once the deficiency is corrected, hypercalcemia can then develop. Alkaline phosphatase is a marker of bone turnover that may be elevated with primary hyperparathyroidism, but it's not a test I routinely send for diagnosis. For symptomatic patients, the decision to take a patient to the OR is straightforward, but for asymptomatic patients, the NIH has published criteria for parathyroidectomy, and these include several criteria that have gone through different renditions, the most recent, which is from 2015. And this includes elevated serum calcium, reduced creatinine clearance, age under 50, hypercalciuria, or marked bone disease. So the rationale is that surgical intervention will improve quality of life in these patients who are at high risk for developing kidney stones, accelerated bone loss, osteoporosis, and other sequelae of the disease. For many of us endocrine surgeons, these guidelines are often taken with a grain of salt, as we prefer to prevent progressive bone loss rather than watch the insidious process once the diagnosis is made. Imaging studies are an important component of the primary hyperpara workup, although they're not necessary for making the actual diagnosis. As mentioned before, significant bone disease is one of the NIH criteria for surgical intervention, and primary hyperpara often affects the cortical bone of the forearm and the hip over the spine, so this can be an important distinction. In terms of localization studies, it's important to note that traditionally, foregland exploration was considered the standard of care for primary hyperpara until the 1990s. But advances in imaging modalities such as ultrasound, here you can see a parathyroid adenoma, sestamibi, as well as 4D CT, have improved localization, enabling surgeons to offer a minimally invasive or focused approach in the case of single gland disease. Once a diagnosis of primary hyperparathyroidism is made, this slide gives a general overview of the next steps to consider prior to surgical intervention. So our practice is to obtain an ultrasound prior to surgery to evaluate for concomitant thyroid disease. And if a nodule is found, the appropriate workup is then carried out as previously discussed. If a single parathyroid adenoma is localized, the next steps are to consider other patient factors such as renal disease, age, prior lithium use, or adenoma size, as these factors can increase the likelihood of multiglandular disease. So in this situation, proceeding directly to a foregland exploration with or without intraoperative parathyroid hormone monitoring is definitely an option. If the patient doesn't have any predisposing factors for multigland disease, some surgeons will still proceed directly to the OR, whereas others might consider doing another imaging modality such as sestamibi or 4D CT. And this is really to obtain concordant imaging, and we've shown that when you have two different imaging modalities that demonstrate a single disease gland, that unilateral neck exploration is an option with or without the use of intraoperative parathyroid hormone monitoring. And finally, if ultrasound is equivocal, whether it's negative or demonstrates multiple adenomas, again, some surgeons will just proceed directly to the OR for the traditional foregland exploration, and others prefer to next proceed with a sestamibi or a 4D CT to try and localize the gland. And depending on these results, if there's something that is found, a unilateral exploration can be performed, or a bilateral neck exploration. So again, in general, imaging is a helpful adjunct to surgical planning, but it's not a substitution for a thorough understanding of neck anatomy and parathyroid physiology, and all endocrine surgeons should be comfortable with performing the standard foregland exploration. I wanted to spend a little time discussing minimally invasive parathyroidectomy, also called MIP, and the rationale behind this surgical approach. For those of you who are not familiar with the operation, this slide shows nicely a parathyroid adenoma, and it can be resected through a small 2 to 3 centimeter incision. So compared with the traditional bilateral neck exploration, MIP allows surgeons to resect a single gland through a small incision without dissection on the contralateral side. So MIP offers the patients the advantage of a smaller incision, decreased operative time, and fewer complications, including nerve injury and permanent hypoparathyroidism. Many surgeons will use intraoperative PTH monitoring as an adjunct during these cases, and a sample of blood can be drawn at the start of the case, as well as 10 minutes after resection of the index lesion. The half-life of PTH is very short. It's roughly 2 to 5 minutes, depending on normal renal function. And surgical cure is based upon the Miami criteria, which requires that post-resection PTH drops 50% relative to pre-resection PTH levels after 10 minutes. These post-resection PTH levels must also fall within the normal range. Studies have looked at cure rates between minimally invasive parathyroidectomy and standard neck exploration, and they are generally comparable, although recent studies have now started to question the long-term durability of MIP relative to foregland exploration. Given the additional costs of IOPTH monitoring, as well as reported false negative rates of 6 to 9% in the literature, our group at Brigham questioned the utility of IOPTH monitoring in patients with concordant localization. We had previously published this data investigating the role of IOPTH monitoring during MIP in cases of primary hyperpara with concordant localization. And we found that the surgical failure rates in our patients with concordant imaging was only 1% when IOPTH monitoring was used versus 2% when it wasn't used. So our findings concluded that the use of IOPTH did not significantly increase the success of this minimally invasive approach with dual localization. And since our publication, other studies have corroborated our findings. Overall, the literature suggests a surgical success rate of 95 to 98% without IOPTH versus 97 to 99% with IOPTH. As our previous study was a retrospective analysis, we then designed a new protocol for performing minimally invasive parathyroidectomy without IOPTH monitoring in patients with concordant localization. And we sought to validate the effectiveness of this new protocol through a prospective study and hypothesized that our surgical failure rate would be 2 to 3% for patients with concordant localization. Our study was a prospective cohort, and it was conducted from October 2005 to September 2009. We used this protocol for all patients with primary hyperparathyroidism who had concordant localization and were undergoing minimally invasive parathyroidectomy. Our outcome measurement was the incidence of surgical cure following minimally invasive parathyroidectomy without using IOPTH. So here is our study algorithm. We first identified all patients with primary hyperpara treated at our institution during the time period, and only patients who had concordant imaging by ultrasound and MIBI were included. Those who were qualified for minimally invasive parathyroidectomy then underwent surgery without IOPTH and were followed for cure over the next 6 months. Patients who were not normocalcemic after 6 months underwent further workup and reoperation. We identified a total of 324 patients with primary hyperpara who underwent parathyroid exploration during our study dates, and 136 of these patients had concordant imaging by MIBI and ultrasound. In 17 patients, they were not qualified or excluded for surgery by minimally invasive parathyroidectomy, and this was due to exclusion criteria such as renal failure, prior lithium use, or enlarged glands on ultrasound. And again, these are all predisposing factors for multiglandular disease. So 119 patients were scheduled for minimally invasive parathyroidectomy. Of these patients, 115 were cured surgically, and this was a 97% surgical cure rate. 4 of these patients had elevated calcium levels during the 6-month time period that we followed them, necessitating reoperation. And as part of our new protocol, we did examine the ipsilateral normal parathyroid gland in order to avoid missing undetected multiglandular disease. So of note, here you can see that 13 of our patients scheduled for minimally invasive parathyroidectomy were converted to bilateral exploration. So the 13 patients that underwent conversion occurred based on criteria for intraoperative suspicion of multiglandular disease. So this included enlarged glands over 2 centimeters in size, or if there was an abnormal appearing second gland during the surgery, or sometimes there was obscure anatomy that that made the surgeon then look on the other side to clarify the anatomy. So 7 of these 13 conversions ultimately identified multiglandular disease or double adenomas that were missed on imaging. 6 of these cases were actually apparent from examination of the ipsilateral second parathyroid gland alone. And then finally, of the 4 surgical failures, all 4 of the cases had a near adjacent but unseen second adenoma on reoperation, suggesting that visualization of the ipsilateral gland was actually missed during the original surgery. There was no significant difference in the cure rate following MIP without IOPTH for this prospective study compared with our previously published retrospective analysis. And you can see here that there was a 97% cure rate versus the previous study. So in conclusion, our data demonstrated that focused parathyroid exploration without IOPTH can be successfully performed in patients with concordant localization by MIBI and ultrasound. We also concluded that identification of the second ipsilateral gland is critical to ruling out undetected multiglandular disease. So as a result, we've adjusted our current protocol to include a low threshold for sending a frozen section biopsy of the ipsilateral normal gland to obtain pathologic confirmation that the tissue in question is really a parathyroid and not just a lymph node or some fatty tissue. Based on these studies, IOPTH is often not sent at our institution when a patient has concordant imaging. However, some of our surgeons do still prefer the 4-gland exploration as the default, whereas others will use the data from the ultrasound to dictate their surgery of choice. As our experience with 4D CT increases and the image quality surpasses that of SPECT CT on cystamibi, many surgeons are now using 4D CT instead of cystamibi as their imaging modality of choice when ultrasound fails to localize an enlarged parathyroid gland. And here you can see a nice example of a left parathyroid adenoma during pre-contrast phase. And during the early arterial phase when contrast is given, both the thyroid and the parathyroid adenoma or gland should light up. However, during the delayed or venous phase, contrast is retained within the thyroid where it starts to wash out in the parathyroid. So hence this is called the 4th dimension when talking about the 4D CTs. And I thought I'd finish up our parathyroid section by talking briefly about a couple of cases. The first case is a patient I saw, a 57-year-old female, who had an elevated calcium of 11.2 to 11.4 on routine laboratory tests. She did have an elevated PTH, 149. So again, this is a clear-cut case of primary hyperparathyroidism. She endorsed a couple of symptoms, including mild fatigue, bone and joint pain, and difficulty with concentration. However, she didn't have any nausea, no abdominal pain, or other constitutional symptoms. There was no other history of kidney stones, no family history, no prior radiation exposure, and her bone density scan showed signs of osteopenia. And here, she had her usual workup with ultrasound. This is a sagittal cut, so you can see part of the thyroid here, the trachea underlying it, and here's a nice hypoechoic round parathyroid adenoma. And again, this was on the right side. And she also underwent a cystamibi scan. This is a very typical demonstration of a cystamibi with the thyroid lighting up as well as the salivary glands. And here you can see this little teardrop extending just below the right thyroid lobe. And this correlates with that ultrasound finding that we just saw of the little parathyroid adenoma hanging off that lower pole of the thyroid. On the delayed phase of the cystamibi, the contrast should wash out of the thyroid and retain in the parathyroid. That's kind of the classic finding. It's not quite as clear on this imaging, though. So I took her to the OR, and we performed a focused right parathyroidectomy, so just on that one side. We took out a 1.1 centimeter parathyroid adenoma and also identified the ipsilateral normal gland. She had an enlarged parathyroid that was heavier than normal. Typically, parathyroids are 40 to 60 milligrams, so this is about 10 times the normal size. No IOPTH was sent as she had concordant imaging. And postoperatively, her levels dropped nicely, so 9.5 and PTH 28 in the normal range. We do check calcium and PTH levels for 3 to 6 months following the surgery just to ensure a durable cure. And I also typically maintain my patients on calcium supplementation for about a year during this active phase of bone remodeling and bone rebuilding in order to try to rebuild bone that they've lost during their time of the parathyroid disease. As a second case, this is one I did recently. It's a younger patient, 44, and she did have calcium levels that were elevated in the high normal range. Her PTH, however, was clearly elevated inappropriately, and this patient had pretty profound vitamin D deficiency. And as I mentioned before, these patients often have lower than typical calcium levels, and once her vitamin D levels were fixed, her levels of calcium also increase. So vitamin D deficiency can mask some signs of primary hyperparathyroidism if clinicians aren't looking carefully. So she did have some symptoms, including fatigue and muscle aches. No kidney stones, no family history. Her bone density scan showed osteopenia, which is a little unusual for a patient this young, suggesting that her parathyroid disease was probably ongoing for quite some time. Her ultrasound, however, was negative for a parathyroid adenoma. So in this situation, I did proceed next to the 4D CT. And here you can see a nice picture. The green arrows kind of give it away, but there's a nice right posterior parathyroid adenoma seen on the axial as well as the sagittal sections here. Here you can see it just on top of her spine, her C-spine. And in many cases, the ultrasound isn't always able to visualize very posteriorly located parathyroid glands, which is very typical for this case. And these are often descended superior parathyroid glands, which like to go posterior right on top of the C-spine. So she also underwent a focused parathyroid exploration, but since I didn't have concordant localization, I did perform the IOPTH monitoring. And her pathology results, you can see again a 1.7 centimeter right hypercellular parathyroid gland. Again, this is an enlarged parathyroid adenoma and also a heavier than normal gland. For her levels, pre-PTH before resection of the gland, it was 186, and 10 minutes after resection of the adenoma, the PTH dropped nicely down to 32. So again, the Miami criteria states that it should drop by half as well as down into normal range for surgical cure. Postoperatively, she did very nicely. You can see her calcium level is actually dropping quite low, and this, I think, again, is part of her vitamin D deficiency. So she's still on calcium and vitamin D supplementation as we try to encourage her to rebuild some of that bone loss. So this brings us to the last topic in our endocrine discussion, the adrenal glands, and I will touch on this briefly. As a review, the adrenal glands sit on top of the kidneys, and they're located in the retroperitoneum. And they're comprised of the outer portion, which is called the cortex, shown here, and the inner portion, which is the medulla. The cortex is responsible for secreting glucocorticoids, mineralocorticoids, and sex hormones in response to signals from the hypothalamus and pituitary gland. The adrenal medulla, shown here, secretes epinephrine and norepinephrine in response to signals from the sympathetic nervous system during times of stress. There are multiple adrenal disorders that may require surgery, including benign adenomas, and these are often incidentally diagnosed on imaging for an unrelated workup. The typical cutoff for surgical intervention of a non-functional adrenal incidentalloma varies, but it's generally around 3 to 4 centimeters in size. Patients should be followed carefully for repeat imaging every 6 to 12 months, as well as annual hormone testing. Adrenal cancers are quite aggressive, but also quite rare. They are often invasive and metastatic at the time of diagnosis, and surgical resection should almost always be performed open in order to optimize chances for clear margins and cure. Adrenal cancers are sometimes symptomatic due to excess hormone secretion or from mass effect. Other tumors may be functional without being malignant and are characterized by excess hormone secretion such as aldosteronomas, pheochromocytomas, paragangliomas, or testosterone, estrogen, or cholesterol secreting tumors. Finally, metastatic disease from breast, lung, or renal, or other sites is another indication for adrenal resection, especially if the patient is symptomatic or it is the only additional site of disease. Imaging for adrenal disorders usually includes CT, MRI, or MIBG scans, and characteristic imaging features are helpful for determining the nature of the adrenal lesion in question. Pictured here is a patient with a large left pheochromocytoma that is clearly visible on CT as well as on MIBG scan. Recently, dotatate scans have become more common for imaging neuroendocrine tumors, including adrenal lesions. There are several different techniques for approaching the adrenal glands, and the disease process, prior abdominal surgery, and surgeon preference all play a role in deciding the optimal surgery for the patient. The open approach can be performed through a standard midline incision, which allows for excellent exposure and is often used when adrenal cancer is suspected to optimize access to the surrounding organs and allow for en bloc resection of invasive cancer if necessary. The thoracoabdominal approach is a larger incision that extends posteriorly to allow for the greatest exposure of the adrenal gland and is often used for a particularly large or invasive tumor. So, for example, you can see here an en bloc resection of an adrenal cancer, as well as the kidney and the spleen that were removed as part of the specimen. The laparoscopic approach is frequently used for smaller tumors and allows for removal through several small laparoscopic ports. Both adenomas and functional tumors are amenable to this approach, but surgeons should always have a low threshold to convert to open if any stickiness or invasion is encountered, which is suggestive of malignant disease. Laparoscopic surgery is very well tolerated, and many patients can be discharged the same day or after an overnight stay in the hospital. Finally, adrenal tumors can be accessed through the retroperitoneum, and this is an especially nice approach if a patient has had prior abdominal surgery, so one can avoid previously scarred planes. Here, the patient is positioned such that the ports are placed in the flank to easily expose the kidney, adrenal, and neighboring vessels in the retroperitoneum. Since the abdominal cavity is not entered, patients recover quite quickly with minimal pain. The main downside to this approach is if one is dissecting on the right side and inadvertently enters the IVC. In this situation, vascular control is challenging, and the patient must often be flipped over and opened from the front. And this can cost precious minutes during a time of active bleeding. So for this reason, some surgeons avoid performing retroperitoneoscopic adrenalectomy on the right side to avoid this complication altogether. Thanks again for joining me in this discussion on updates in endocrine surgery. And I leave you with this public health reminder that thyroid cancer rates are growing 6 times faster than prostate cancer. So don't forget to check your neck. Thanks very much.